Hey Cam followers, it is Monday at 7 p.m. So this is a little bit out of the ordinary, but basically I had the opportunity to get the lovely Dr. Simon Tappin live and I could not say no. So I'm in my camper van because I'm officially on holiday. Simon is officially on holiday. So we're going to just keep it really chilled and we're going to have a chat about immune-mediated polyarthritis. I actually went to university with this dude, so we've got a lot of history together, but I'm going to let him introduce himself to you. So Simon, tell us a bit about yourself.
Hi, Hannah. Yeah, probably best we don't talk much about uni. Never mind. Yeah. I'm an internal medicine specialist and I work at Dick White Referrals, where I head up the internal medicine department. We've got quite a big team of people, so about 30 people in the medicine team. So it's quite busy, which is good. So I really enjoy working up internal medicine cases, and IMPA, or immune-mediated polyarthritis, forms a part of what we talk about. And then fairly busy at home as well. So 2 small children, 3 dogs, 3 horses, chickens, doves, 2 cats. So yeah, it's fairly busy. So yeah, my week off being on holiday hasn't really been much of a rest. We've been rebuilding a wall I managed to knock down last year. So it's all been quite good fun.
Yeah, well, Simon actually used to do quite a lot of agility, didn't you?
Yeah,
so
yeah.
That is into agility would be quite interested to follow this live. Because we're both going to crack on, let's get straight into it. The reason that this is here, guys, is that quite a few people that stumble across CAM or get sent to CAM because of our holistic management approach aren't your average OA cases, osteoarthritis cases. A lot of people that are coming our way are other conditions that have musculoskeletal debilitation. So immune-mediated polyarthritis is a group of people a group of animals that we're now beginning to kind of take under our wing. And we've had many, many requests for more detail about it. It's an extremely complex topic that I felt so out of my depth to talk about. So I've got Simon to come and talk to us. So we're going to crack straight on. We've got a little bit of an agenda, and we are open to questions. We're going to chat through to about 7:45, and then we're going to do our 10 top tips about OA management, i.e. musculoskeletal disease, how to manage it, things that anybody of any physical, emotional, or financial background can put in place so they can look after their dogs better. So please do stay with us for the end. So we're going to crack on immediately with what is immune-mediated polyarthritis. Go for it, Simon.
Well, I think that's a really good question, because it is a group of diseases. It's not just one straightforward condition, but essentially it's an inflammatory arthritis that is caused by inflammation in multiple joints, usually the distal joints, so the carpi, so the wrist joints at the front, and the hocks, so the ankle joints at the back. And usually that's a sterile inflammatory response. So usually it's the immune system misbehaving or overreacting to cause inflammation in the joint that then is quite painful. So it causes swelling in the joint, which causes mobility problems. But if you can control the inflammation, there's no damage to that joint, in the way that that's very different from osteoarthritis, where there's always going to be a physical change in the joint. Immune-mediated polyarthritis, or IMPA, which is perhaps a little easier to say, it is an inflammatory condition that if you can control the inflammation and understand the inflammatory process and get that under control, the joint should go back to having its normal function, and the dog essentially is better as a result of that. But that can be quite tricky to try and diagnose, and then to manage and to try and treat. Most of the time it's what we call primary IMPA, or primary immune-mediated polyarthritis, which has got the condition of type 1, which is essentially where the immune system just starts misbehaving and you get this inflammatory response. And most of the time you don't work out what the trigger to that is. So it's just an overreaction in the immune system, possibly caused by molecular mimicry. So the body is responding to something else. And in the course of responding to a virus or a bacteria or some other disease, we get inflammation in the joint that causes a problem. But occasionally it is caused or triggered off by other things in the body. So disease at other sites, the bacterial infections. So that's classically how Lyme's disease would cause joint inflammation. Or we can see it secondary to gut-based disease or to cancerous conditions. So reactive arthropathies, enteropathic enteropathies, and oncological arthropathies, which are caused by disease in other places. And those become a little tricky to manage, because they're things where we're trying to manage the underlying disease rather than we're trying to manage just the inflammation. So those are a little bit different from what perhaps we'll be talking about the rest of this evening.
Yeah, I think that needs a little bit of clarification, because I know as a vet myself, it gets really confusing with the different terminology, and depending on where you get your information from, people are using different terminology. It makes it even more complex. So would it be fair if we stick to the type, so type 1 to type 4, or is that too simplistic?
I think that's, that is usually what people are talking about. And I guess the difficulty we're talking about inflammatory arthritis is because this is quite an uncommon condition in people. Most people, if they have an inflammatory or immune-mediated arthritis, have rheumatoid arthritis, which is an erosive arthritis. So it's really damaging to the joint surface and therefore quite debilitating as a result. But rheumatoid arthritis in dogs is very rare. I think I've seen just one case during 15 years I've been in specialist practice. So it's a very different condition in that regard. It's not something we commonly see. Whereas the inflammatory arthritis, they don't tend to damage the joint as such, that they often refer to as non-erosive. And then there is that category of 1 to 4, but the 2, 3, and 4 in that, which are the sort of unusual ones that are triggered off by something else, are also quite unusual. We don't see those very often.
Okay, cool. Let's do that rheumatoid chat quickly, because we have many people that come into Holly's Army, or they have chats with us or go on the forum, and they say, my dog's got rheumatoid arthritis, but I think they probably haven't. I think they're just getting the terminology mixed up. Can you just clarify the difference in humans between osteoarthritis, rheumatoid arthritis, and then just bring it into the dog world so people can understand, as you say, how rare it is? So, just clarify that for us.
Yeah, so rheumatoid arthritis is where you have an immune-mediated attack essentially against the joint surface, and that's an erosive attack. So it's essentially taking apart and destroying the cartilage layer that's present. That is something that's usually characterized by quite severe pain, and usually you can find rheumatoid factor in the blood on blood tests as well. Though that's quite a sensitive test in people, so if you look for rheumatoid factor and find it with inflammatory joint disease, it's usually because of rheumatoid arthritis. And so people have kind of taken those descriptions of that disease and tried to apply them to canine medicine, and we don't see erosive joint disease very often where the joint surface is eroded. We see arthritis, osteoarthritis, where there's proliferative new bone and joint dysfunction that forms, but it's not that erosive cartilage destroying type disease. And rheumatoid factor can be measured in dogs, but it's the human test that we're using, and it's not very specific. So yes, we'll find it in rheumatoid arthritis, but we find it in lots of other conditions as well. So it's not a test that gives us a yes or no condition. So I don't run that test very often. I don't know very many people that do, but it tends to be something that is run in clinical practice a lot more, where people are looking for arthritis conditions or dogs that have inflammatory joint disease, and it comes back with positive results, often because they're falsely positive. And then dogs get treated a little bit wrongly as a result, because they get put on immunosuppressive steroids and it needs quite aggressive management. Whereas I think a lot of those dogs probably do have osteoarthritis that are just perhaps also have a rheumatoid factor that is a little bit elevated, and that can create quite a lot of confusion within the vet population as well as with owners.
Yeah, because I just know when I listen to my parents and that kind of age group, quite often they'll talk about rheumatism, and they'll say, oh yeah, my dog's got rheumatism, or my dog's got rheumatoid arthritis, and I say, no, it probably hasn't. No, we're just getting a bit of terminology wrong here. So just be a bit careful, that guy. They're very, very different conditions. So let's carry on with the immune mediated and sticking into that category, and just clarify again the type 1s to type 4 and the fact that we often are talking about type 1, but just do that again, because I know a lot of people find this really confusing. So type 1 is more of the idiopathic. We don't get to the bottom of it.
Yeah, so idiopathic is type 1. And idiopathic is just a posh way of saying we've no idea what's causing it. So often that's referred to as primary disease. So it's thought to be the immune system misbehaving. And that's the kind of molecular mimicry that the body's probably been responding to something else. But in the course of that, the joint has been a focus of that. So something in the joint looks very similar to what the immune system has been trying to get rid of. And that may be something that we're not aware of. It may be a subclinical infection. I mean, we all have those all the time, and our immune system's doing a lot of stuff that we don't recognize and realize. And then the immune response is then focused against things that are actually substantive parts of the body, and that causes a lot of inflammatory reaction and causes a problem. So that primary disease probably represents 90-95% of the IMPA cases. The others are quite unusual things. It's usually the primary disease that we don't find a cause of. We do go looking for the cause in the others, though, because if there is a reason why the immune system is misbehaving, we need to treat that reason rather than just trying to suppress the immune system. And I guess that's what we do with primary IMHA. We're trying to damp down that immune response, and that usually is quite successful in dealing with the condition. But if there's an underlying trigger that we can't treat, that's always going to be there as a drive for that inflammatory condition, and then that becomes a problem that is more difficult to manage. So we always look for infections at distant sites, which is type 2. There aren't many infections that we can't usually spot easily. So often if the animal does have one of these sort of reactive arthritis, the animal is sick for a reason, and we see why the animal is sick. But I guess Lyme disease and another of the tick-borne diseases, anaplasmosis, would be the kind of diseases that can cause that. They're not very common. Lyme disease in people is quite a common disease. We see it and we know more about it because people are worried about ticks, and it's become easier to diagnose as well. But dogs are thought to be about 10 times more resistant to Lyme disease than people. And actually dogs don't tend to sort of classically get Lyme disease. I'm quite interested in these kind of joint conditions, and Lyme disease is one of the things that I've been interested in. We've sort of seen maybe 4 or 5 cases over the last 10 years. So it's not something that is very common to see. But if you treat the infection with antibiotics, the immune response goes away. So you treat them with antibiotics and treat the underlying cause, rather than giving a lot of drugs to suppress the immune system and damp down that reaction. So it's important that you look for Lyme disease. But looking for Lyme disease is probably another discussion itself, because it's quite hard. It's a really good bacteria to evade the immune system. It lives in cartilage, but it's really difficult to find.
Okay.
And then the others
but you can have other things like endocarditis and other areas of infection, can't you?
Yeah, I guess that would be difficult when it's.
We prep so that people understand why the workup for immune-mediated polyarthritis can be quite lengthy and expensive. Yeah. And by going through type 2, 3, and 4, people go, oh, I get it now. You are looking for other things. So other areas of infection that you might be looking at in the course of your workup because of type 2?
Yeah. I guess we're looking for any infection at a distant site that can be cryptic. So endocarditis would be one of those. But then I guess we're also then trying to say whether this might be a septic thing versus an immune-mediated condition. And that's one of the things that's really difficult. Essentially, endocarditis is infection of the heart valves. And it's not a very common condition, but if you've got a low-grade bacterial condition, because of the pressure in the heart, the bacteria get sort of forced onto the heart valves, and then it's very difficult for the body to clear the infection. So you get intermittent showering of the bacteria around the body, and those can then become lodged in the joint, and you get low-grade septic infection in the joints. But then that's a very different condition. It's septic arthritis rather than it's immune-mediated arthritis. But you can also get the presence of that infection being the trigger to the immune system misbehaving. And then that becomes very difficult because you're wanting to try and treat the joints with steroids because there's an inflammatory condition, but you've also got a very serious bacterial condition that needs treating with antibiotics. So yes, that's really important that we do that workup. Whilst these conditions are quite rare, if we don't treat them correctly, they can be a complete disaster if we treat them wrongly.
Yeah, and that would be a case where somebody just putting a dog on steroids and not actually finding that underlying infection is a bit of a oopsie. What about other areas? So urinary tract?
I guess anywhere is possible. A chronic urinary tract infection, I guess, could be a trigger for IMPA. So yeah, I mean, I guess our workup for looking for secondary causes would be to do some blood work to try and assess the organ function, to do some chest X-rays and an abdominal ultrasound, and probably to take urine samples. So we're looking generally just to see, is there anything else that's going on? I guess if the immune system's misbehaving as well, we can also see that there are other components of immune-mediated disease. And that's a bit like lupus in people, where if the immune system is doing one thing that's a little bit unusual, sometimes it will be doing other things as well. So we can sort of sterile meningitis and other conditions that form sort of part of that lupus condition. But again, they're quite unusual, and usually fairly apparent when you start looking for them.
Yeah. Okay, we'll come back to that. Seriously, guys, I spent probably about 2 or 3 hours yesterday just reading around, just trying to remember stuff from university and kind of be a little bit more current. And it is so complicated. I'm going to keep trying to keep it as clear as possible. So let's go on to type 3 and then type 4, and then we can do SLE, so lupus. Then we can talk about a few breeds that are predisposed. But type 3, tell people about type 3.
The type 3 is enterogenic, so essentially it's triggered off by GI disease, so gastrointestinal conditions, so conditions that affect the stomach or the gut. It's quite unusual. We don't see it very often. The categorization 1 to 4 comes from human medicine, where it's a little bit more commonly seen. And usually it's quite associated with quite obvious GI upset. So you know about it because the dogs are vomiting and they have diarrhea or they have weight loss as a result of poor absorption. And usually if that's a condition, it's triggered off either by bacterial disease, so things like Salmonella or Campylobacter, or it's another immune-mediated condition like inflammatory bowel disease. And that's where we come back to things like lupus, where the immune system is doing more than one thing that's causing a problem. But yeah, it's not a very common condition to see GI disease trigger off joint changes. Yeah.
Okay. And then type 4.
And type 4, I guess, is another one of the more common ones, in that what we're seeing is that there can be a cancerous condition, so neoplastic or oncologic arthritis. And there you see a tumour somewhere else in the body that forms something that's very similar to the joint that the immune system is trying to get rid of, because our immune system will try and get rid of some of the cancerous cells because it sees them as foreign. And that cross reaction then causes an inflammatory arthropathy. You can usually control that, but you also need to try and treat whatever the cancerous condition is. If you can remove that with surgery, great, the condition should come under control. If it's one of the more systemic cancers, so one of the sort of lymphoproliferative diseases like leukemia or lymphoma, then those can be much more difficult to control, because you're thinking about drug management and chemotherapy and all the sort of chat that goes with that to make sure that we're maintaining quality of life and making sure that animals are treated as well as is possible. But yeah, those can be more tricky to manage because you're trying to actively manage the oncological condition as well as trying to manage the joint inflammation.
Okay. And then we've got some breed predispositions as well, haven't we? A couple of breeds, like the greyhound, was it, that I was reading, is prone to?
Yeah, sight hounds tend to be a bit overrepresented. So we see greyhounds and whippets, a lot of whippets actually, with IMPA and steroid responsive meningitis as well, which tends to be a very similar condition that affects inflammation around the spinal cord, which you often see with immune-mediated polyarthritis. And that's, I guess, where quite a lot of the literature is unclear, in that a lot of these conditions get lumped together, and actually teasing apart what people have been treating and what people have actually diagnosed can be quite tricky. Because over time it's changed, and our nomenclature and what we're meaning by different words has also changed as well, so that becomes quite tricky to know.
Yeah. So we've had a couple of people. Hey Greg, nice to see you. Greg McGarrow and David Smith. I have a whippet that had IMPA in a hook, off steroids now for a month and no relapse yet. Fingers crossed. We're thinking of you, David. Hey Lynn and hey Rosemary. So just because we spent some time talking about all the different causes, all the different categories of immune-mediated polyarthritis, I hope you guys can now understand that it's not a case of a 15-minute consult. There is no way in the world that a vet is going to be able to go, oh, you've got a couple of swollen joints, here you go, it's IMPA, there you go, here's some steroids. It doesn't work like that. You know, these are pretty tricky to work up. You're going to have a really good relationship with your vet. You're going to have to accept that your dog's going to have multiple tests done. So say that you've had a dog turn up at your referral, it's just arrived at Dick White referrals, and the first opinion vet's not done very much, okay? They're all sick with COVID, and they've sent this case to you, and it's got bilateral swollen carpi, maybe, you know, a little bit pain in the hocks, and it's a whippet. So what are you going to do? What is the kind of procedure so people know what to expect? Something I really want to try and get across is that vets aren't just doing tests for no reason at all. There is a methodical approach to doing the workup to get the answers. So what would be your process, Simon?
So when we see cases like that, the first bit that we try and understand is actually what's going on with the patient. So we take quite detailed histories, which I know is quite frustrating because somebody turns up and says, well, my dog has got this, but we want to make sure that that's actually right. So having told everyone along the way to getting to see us the story, we want to hear that story again. And we'll often ask the same questions repeatedly, but in slightly different ways to make sure that we actually do understand what's going on with the patient. So usually history taking at referral level takes 30 or 40 minutes. It's not a quick process. And for you guys to do that in 15 minutes in practice is, it's not possible. You're asking a few of those questions. So it takes a long time to understand that. And then we'll examine the patient. And that's really, I guess, where a lot of this still comes from in terms of understanding what's going on with that patient, in that it may just have effusions in the hocks, but these are quite subtle things and they're quite tricky to actually look at. So we'd want to check all of the joints and make sure there wasn't effusion, but also to do a neurological exam so we can look at the neck and make sure that all the reflexes and things are okay. So we're doing a very detailed clinical examination. And then if we were finding that there were multiple joints that were swollen, we'd want to start by doing some blood tests, I guess, to understand that there's nothing else that's going on. There's a lot of these animals, usually sort of middle-aged, but I guess we can see them in older animals, and that's where we worry about other things that are happening and other causes. And also looking for evidence of inflammation, which is the cause. So we often see that the white blood cells are elevated, and then we use a marker called C-Reactive Protein, or CRP, which we might, I guess, come back to, which is quite a nice marker of actually...
Yes, we're going to come back to that.
There. So that was quite a nice sort of understand that there is inflammation. And then we would want to do some screening investigations to look for underlying causes, so x-rays of the chest, abdominal ultrasound, and we would usually take joint x-rays, so to look for any evidence of any erosion in the joint. Usually they're negative x-rays, they just show that there's a swollen joint, the joint itself looks okay, but that's really useful information for us to have, because if there's rheumatoid arthritis and destructive change, then the prognosis is going to be much worse, because the function of that joint is always going to be affected. Whereas with IMPA, if we can control the inflammation, which is a tricky thing in some of the cases, but in the vast majority do very well, then the joint function should be very normal. And once we've done that under anaesthesia, we would take some joint taps. So we would take fluid from the joint to look to see if there's any evidence of infection, and also to look for the degree of inflammation that's present. And that helps then to diagnose the condition. And we usually try and tap maybe 5 or 6 joints. So usually we tap all the distal joints, so the carpi, the hocks, and then 2 of the bigger joints, so the elbows or the stifles. And you're looking for inflammation in at least 3 of those joints for it to be polyarthritis.
Right. See, guys? Oh my God. This is, if you're really lucky, a whole day thing. But most referral centres, that's potentially even a dog being in overnight, 2 days, trying to get all of those disciplines done. It's complicated. So yes, bear with. I'm just going to see. Oh my God, we've got some questions. Are you ready for this? We're going to have a pause. Hi, I run Immune-mediated polyarthritis support Facebook, and wrote an owner article for CAM about a year ago. I wonder if you can give some comment or advice about the best ways to treat things like urine infections, which seem to come on due to reduced immune system due to steroids, etc. But then when we treat with antibiotics, that can cause a flare in IMPA. This has happened to our dog Ozzy a few times. Can you see that, Simon? Let me put it, I'll put it on show.
Yeah, I think that's tricky, isn't it? I guess there are a proportion of these dogs that are really difficult to control, and I guess the ones that we treat and they get better and they don't need ongoing care are great, and then there are a proportion where it's really difficult to get them off medication, or we see that there are recurring flare-ups, and those dogs seem to be super sensitive to things. So if we're treating them with antibiotics, the immune system can react to those antibiotics, and that triggers a flare-up, and then that's very difficult. And because you're using a lot of immunosuppressive medications, which I think is what's happening here, the dog's more likely to get urinary tract infections, which then means you need to use antibiotics to clear the urinary tract infection. You end up with a cycle where that becomes tricky. So yeah, that's really difficult without knowing a bit more about what's going on. I don't think we can be that specific, but trying to use drugs perhaps alter the immune system in different ways rather than relying on steroids as the mainstay of that immunosuppressive protocol might be a better way in dealing with things. But yes, it's difficult. It's very difficult, I think, that question.
Okay, and she then carries on. Also, I know a lot of people on our group are concerned about whether booster injections cause IMPA. Is there any evidence? Oh, that was on our list. Well, we can progress on to what causes immune system to react. Do you want to go there? Do you feel that we've dealt with classification well enough?
Yeah, I think so. Yeah. Yeah.
Okay. So, what kind of causes? We've done all our types, but there is always that drugs, vaccines, etc. Let's talk about that.
I think that's difficult because I guess we worry about vaccines as the cause for lots of immune-mediated diseases. So not just the joint diseases where there perhaps isn't that much evidence as to whether vaccines were involved or not, but some of the sort of inflammatory arthritis and then the conditions where we see red cells being destroyed and platelets being destroyed. So immune-mediated anemia and thrombocytopenia, where there has been quite a lot of controversy as to whether vaccines could be the trigger of the immune system causing the problem, and quite a lot of conflicting evidence. So there's papers that suggest that maybe it is temporarily associated, and then some papers that suggest that maybe it isn't, and then some more recent work where we've reviewed dogs that have had those immune-mediated conditions where they've been vaccinated again, and they haven't seemed to have had flare-ups of those conditions. But that's been done with conditions other than polyarthritis, and I guess we're always concerned whether we're giving vaccines, and vaccines are to stimulate the immune system to provide a protective support. So we're trying to stimulate, provide antibodies or produce antibodies to try and stop an infection from occurring, to try and minimize that to as little as is possible. So we're not stimulating the immune system to cause. So I guess the current thinking would be that cause the immune system to misbehave, but anything that stimulates the immune system could potentially stimulate a problem or progress a problem where the immune system is misdirecting its reaction against parts of the body that are normal. So yes, we do see these immune-mediated conditions temporarily associated with vaccines because they're essentially pushing the immune system to do more, and we would always be very careful to vaccinate dogs as infrequently as possible. And I guess that's another discussion, but I guess we're vaccinating dogs a lot less than we used to, with the viral diseases doing that every 3 years now, leptospirosis as and when we feel it's appropriate for core vaccines. So trying just to vaccinate as and when and reduce the amount of sort of stimulation to the immune system, I think is certainly a good way forward. But if we've seen cases where we have seen this temporal association, then we would try not to vaccinate them, and there may be a discussion with owners as to whether we should vaccinate them at all. If they're older dogs and they've been well vaccinated, depending on their lifestyle, it may not be something that we consider that we need to do.
Okay, and I think that's a really fair thing to say, is that there's evidence for and evidence against, isn't it? Because I stumbled across a paper where they were saying that there really isn't the link, they can't see it, but in every textbook about immune-mediated, it's always listed as a potential cause, and it's the first thing that vets will say, because it's in our kind of our script, isn't it? Oh, it could be triggered by certain medications, vaccines, blah 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 blah. Okay. Hi Laura, can you send me a link to your group? That's cool. We love people sharing links. That's good. Emily Blackledge. Let's have a look, see if we can get this one across. This is so interesting. Thank you so much. I'm part of the IMPA Facebook group, which has been so supportive. I have a 3-year-old Tibetan Terrier called Disco, who became lame in January and was diagnosed with IMPA in May. We're on a roller coaster with steroids and cyclosporin, but had an amazing vet. Well, that's nice to hear. We love it when people say that they've had an amazing vet. We will talk about the different medications in a bit. We're trying to do a little kind of a flow to this. Let's have a look. There's another one underneath that. Hi from my Rotti, was diagnosed last summer with IMPA. They think it's from vaccines, though they did find a mass on his spleen in April, and they removed the spleen. He's now on 10 mg of steroids. Can a dog go on long-term steroids? What's your thoughts on that?
I guess that's one of those conditions where potentially we don't know what was going on in terms of triggering it off. If there was a mass on the spleen, the vaccines may have sort of stimulated something that was going on a bit further, and hopefully removing the spleen will have fixed the problem, which is great. And then the immune system, I guess, is still overreacting if the dog's still on steroids at the moment, but hopefully that can be damped down. The only way of knowing really whether medication can be withdrawn is to withdraw the medication. The majority of dogs we can take off the medication, but it is trying to sort of treat the clinical problem. And most dogs, if they're doing well, you can gradually reduce down the medication, but we can never ultimately predict what's going to happen when we withdraw the medication. That's one of the difficulties. Some dogs will relapse when they come off the medication, and until we get to the point where the medication is stopped, we don't know which dogs they're going to be.
No, and I think that is something that, again, Cam really tries to bridge this kind of gap, in that vets are humans. We're all the same as you. We do the best that we can, and there are some situations where we have to just say, right, we are not going to know until we try, and you need to trust me, and I need to trust you. You're going to be super observant and tell me when things change, and I'm going to do the best that I can with the information that I have. So in some situations, it really is a team approach. So make sure that you work really hard as well with your vet. It's a two-way street. You have to communicate with each other. Shall we jump into talking about C-reactive protein then? So that how can we monitor these diseases so to give us the best chance of coming off these medications safely? What is a real no-no, and what is this is looking good, let's lower the dose, and how do you do that?
I think C-reactive protein is quite difficult. It's an inflammatory marker. So it's part of the immune response to broad-based inflammatory disease. So we see it go up in lots of conditions. In human medicine, it's one of the main markers they use in A&E to try and document sepsis. So if there's infection, your CRP goes up. And so as part of the basic screen for serious inflammatory disease, it's really sensitive in that respect in people. And that's why we started looking at it in dogs as well. And it is really sensitive for inflammatory diseases. The difficulty, I guess, with immune-mediated polyarthritis is a lot of that inflammation is in the joint. So rather than seeing a systemic inflammatory response, which is what we would see with sepsis or a more generalized infection, some of it's very focal. And so we don't often see the huge elevations in CRP that we do with more generalized disease. But even so, it can be a really useful marker of controlling the inflammation. So we would always measure it at diagnosis or the time we're looking for a condition. And then we would hope to see that that comes down quite quickly with treatment. So I guess for monitoring, we're always going to be wanting to talk to owners because their perception of how the dog is really important and by far away the thing that we're going on most. But also looking at joint inflammation and how much range of movement there is, if there's any pain in the joint, those sorts of things. But CRP can be really helpful, not necessarily for monitoring response in a good way, in the sense if the CRP comes down, the CRP is normal, then that's a good sign, and it's helpful and it's reassuring, but it doesn't completely tell you that the inflammation is under control because the inflammation may be in the joint. I guess the treatment where we use it or where it's helpful is where it's unexpectedly high. So the animal looks okay, but the CRP is still elevated. And those would perhaps give us a bit more indication to be a bit more aggressive with treatment or to hang on with the dose that we're on for a bit longer rather than trying to reduce it a little bit more. So I guess if it's normal, it's reassuring, but it doesn't completely rule out that there could be something going on in the joint that you can't see. But if it's elevated and clinically you think the dog's doing all right, then we tend to take a bit more notice of that and perhaps be a little bit more conservative with reducing doses or a bit more aggressive investigating the problem.
Right, and the other thing is it's not affected by the steroids, so it's kind of independent of the medication that's going into the body. What other things might you do? So like joint tapping, you've done it at the beginning, so arthrocentesis or joint tapping is done at the beginning, but do you use that during the course of the treatment to see whether you're getting on top of things, or are you a little bit less invasive?
I think it depends on the case a little bit. It's difficult because you can't do conscious joint taps. You really anaesthetize the patient to be able to do that. So there's obviously a risk in terms of anaesthetizing the patient. I think if we've got animals that are doing clinically very well, so they're walking normally, they're behaving normally, the joint effusion has gone palpably, and you've got no pain on range of movement and your CRP has come down, then I wouldn't routinely retap these cases. I know textbooks sort of suggest that you should, and people talk about tapping them at different points. But clinically, if they're doing well, we usually treat them with sort of treatment trials and reduce the doses of medication. If you've got those cases where they're more difficult to control, or you've got CRP that's unexpectedly high, then that probably would be the indication for taking an additional joint tap, because it's not a completely benign thing to do. Firstly, to anaesthetize the dog, and then you're putting a needle into the joint, which has a very small amount of risk, inducing infection and things like that. So it's not something that we would do unless we absolutely had to. But yeah, we don't tend to follow up with doing routine joint taps unless there's a clinical indication for that.
Okay, and I think again that's another tangent for me, another opportunity to say about reality. As a first opinion vet who sees these cases at IMPA quite rarely, we will go to the textbooks. That's what we do. We might see a hamster, and then the next thing we're seeing a whelping bitch, and then the next thing we're doing a puppy vaccine, and suddenly we've got a dog in with swollen joints, and oh my goodness, that's a bounce from different conditions. And I'm sure there are some vets that are incredible with brains the size of small planets, but a lot of us mere mortal vets will have to go to text and articles and relatively recent research. And yes, what I've read in the last couple of days has suggested that doing serial joint taps is acceptable. So if your vet does suggest that, and Simon's just said the other, that's just different levels of experience, and that's different levels of, just cases that you've seen, so experience, yeah. Let's have a tangent quickly. Let's hear from Amanda Whiffen. We have a working Cocker Spaniel who woke up on one Sunday morning and could hardly walk. We were diagnosed within 3 days that Woody had IMPA. His left side was conclusive and right side came back non-conclusive. This was in November last year. Started on 25 milligrams of prednisolone, which is a steroid. We are now down to 5 milligrams. So that was November last year. So we're talking about 7-8 months ago now. Going to 2.5 on Saturday for a week and then off them. But he has started scratching and biting his fur. So now has patches of no fur on him. Is this from long-term steroids? Oh, Simon, you're going to become a dermatologist now.
So steroids usually suppress itchiness. So there aren't many conditions that sort of come up that can be caused by steroids that would cause dogs to be itchy. So secondary infection, I guess, could occur. Or we see calcium deposits in the skin sometimes, which makes the skin quite crunchy, that can be caused by steroids, but they're usually fairly obvious that that's the case. So I suspect we're probably getting to a dose that is low enough that we're unmasking something else, the time of year where an allergy or something else is causing a problem, and therefore we're seeing the effect of that. The steroid has been suppressing rather than it's the causing an issue. But again, I guess that's a chat to have with your vet. But there's lots of biting insects, pollens, all those sorts of things that will cause irritation and itching that steroids would have controlled to a good degree. And then as we've dropped the dose down, potentially that's now causing a bit more of an issue.
Yeah. So in your case, don't be surprised if the vet says, "Well, stop. Let's go back a bit. Let's maybe do some sellotape strips. Maybe let's do some hair plucks. We might have to do some scrapes. Let's just be sure of what we're dealing with." There's a real tendency to try and lump everything into one box. We want life to be simple, and we try and get all the clinical signs to fit with the one condition, but unfortunately it doesn't happen like that, and you can get multiple conditions. So bear with your vet and work with them. Oh, you've got loads of questions. Emily Blackledge, I think Lepto4 cause Disco's IMPA. What's your thoughts on that?
So Lepto4 is the new quadrivalent vaccine. So I guess historically we've seen a couple of lepto strains that have caused problems, so Canicola and Ictohemorrhagica, and Canicola is the dog one that's really gone down in incidence because we've vaccinated for it. But we've seen some unusual strains of lepto, so different what we call serovars, so Bratislava, autumnalis, and those have been incorporated into the vaccines and changed in the UK, which is the quadrivalent. It's the 4 types of lepto rather than just the 2 that we've historically used. So there's a new vaccine that came out about 3 or 4 years ago now. And it did seem to be associated with a higher reported incidence of complications when vets started using it. And some of those were just technical, that it caused a bit of swelling when the injections were given. And the VMD, the Veterinary Medicine Directorate, looked into it because obviously there was quite a lot of bad press associated with the vaccine I think we need, because we see lepto because of these unusual serovars more than we see the sort of standard ones now. And they didn't really find that those reactions were because of the vaccine itself. They were no higher than they saw for any of the other vaccines. But any vaccine, as we've discussed, could potentially trigger the immune system to misbehave, or to push the immune system to misbehave. Lepto is a difficult vaccine because it's a bacteria rather than a virus. So a lot of the viruses we use, we change in some way, so they cause an infection, which the immune system can then attack, but they don't cause the clinical signs associated with that. Whereas with lepto, we're using killed parts of the bacteria with something that stimulates the immune system to say, look here, and provoke an antibody response against it. So often they're much more sort of stimulatory to the immune system compared with the inactivated or subunit based vaccines, where the immune system is sort of reacting against a viral infection or something that is changed in some way. So yeah, lepto vaccines probably are the ones where we would associate them with causing more reaction of the immune system compared with the viral inactivated ones. But yeah, I guess there's no way of really knowing that. But yes, any vaccine that's given within a few months of potentially immune-mediated disease could have been linked to the progression of that disease.
Yeah, I think there is, as you say. I can remember when the L4 came out, it was just like, oh my goodness, it was kicking off online and everybody was saying bad stuff about it. So it's quite interesting that they've collected as much data as possible and compared vaccines and the reaction rates. And as you say, they're not too different.
No, I think it's one of those things that there was a big kind of well, not outcry, but there was a lot of publicity associated with it, which was quite negative. And I think a lot of that has settled. I think people are reporting less incidents with it. I think a lot of it came from the formulation when it was injected that caused a lot of re-injection site reactions. But the immune-mediated disease stuff, I think, is the reaction is fairly similar to what we see for other vaccines.
Okay, cool. Jennifer Kim, how rare is IMPA in the vet world? Do you see an increase in IMPA in recent years? Sorry, I'm actually in a car park and all my friends are here, so they keep waving in the windows and I find it very hilarious. It took us 2 weeks and 3 different vets to finally get the IMPA diagnosis, but I know other dogs in the IMPA Facebook group have taken a lot longer. Well, yeah, I'm going to say as a first opinion vet, I don't see it very often. And I think knowing how I probably would behave is that you would treat common as common, and then when it isn't responding to treatment, or if it is really overt, then you kind of go red flag, red flag. I think you are probably in a different category, Simon, because you get referrals, so they're already kind of red flagged and they're on their way in and there's suspicion it's complex. But for a first opinion vet on a 10 to 15 minute consult with you snuck in between another eight consults, they're going to treat common as common, aren't they?
Yeah, I think this question has lots of different points, and I guess it's difficult. The first thing is we don't know how common IMPA is because there are no good detailed prevalence studies to sort of say how common it is. We probably see a case every other week, something like that. So it's a relatively common disease for us to see in referral practice, but we're seeing cases from all over the east of England, so really wide catchment area. So in general practice, it probably is the sort of thing that you might see once a year, maybe something like that. It's not going to be a very common condition. And there's a huge spectrum of the disease, from those that sort of scream at you, I've got IMPA, and there's a really obvious diagnosis, through to a lot more that are quite chronic and quite difficult, especially in the early stages of the disease. And they sort of more manifest as not being quite right or just being a bit under the weather. And it's really quite hard then to do to know what's going on. And that may be where we try supportive or symptomatic treatment first before we see the overt signs of joint swelling. And it's always really difficult balancing that. If you've got a dog that isn't quite right, doing lots of investigations, which may be indicated, or trying some treatment to see whether it works, and balancing out the costs and the risks and things associated with that can be quite hard. So a lot of the time, these non-specific things get better because there's an undiagnosed inflammatory condition or infection that we get right with medication. But when it progresses to something, it is more obvious to diagnose, and then we can be more sure about what the condition is. So yeah, it's tricky when things take a long time to diagnose. That it's very frustrating, but that's often going through that progression of needing to see the disease manifest as something that we understand is IMPA and being able to treat it appropriately, rather than doing a full workup absolutely immediately with every case that comes through the door.
No, and I totally feel for that, because again, as the first opinion vet on the other side of the table, if on the first hint that there was just something slightly wrong, I said, right, I'm afraid I'm going to have to take your dog in. I'm going to be doing 6 blood tests, joint taps, I'm going to be doing an abdo scan, thoracic x-rays, and I'm going to send you home with a bill of probably about £2,500. You just don't do that in first opinion. You would treat common as common, and if it doesn't respond to what you think it might be, then your alarm bells go off and you are able to more confidently have that conversation. And the cases of IMPA that I can remember working up, I had to build a really good rapport with the clients because it was long, it was a long graft, and that was before we even started treatment. Then there's still that relationship that needs to be maintained into the treatment protocol for those moments when you do stop treating them, and having to say, right, did we get it right? Are we able to stay off the medication? So next one, I have a Leonberger that has IMPA since she was 2 and is now 10. She's been on minimal dose of steroids all of her life. Being an old girl now, what is the best way I can keep her comfortable in her old age? I don't want to x-ray her now due to age.
I guess that's difficult, because if the IMPA has been well controlled with steroids at this point, if it's just on a very low dose of steroid, I suspect that the steroids are doing that much to control the immune-mediated disease. But without knowing a bit more about what's happened over the last 8 years, it's very hard to answer that question. So I guess if there are problems, it probably is that the dog has other joint changes. I mean, it doesn't stop you then from getting osteoarthritis as the dog gets older and other conditions that are causing a problem. So that's probably more of a condition that we'd be concerned about. If there was IMPA in a very young dog and it's essentially been treated, that now there may be other changes that are developing in the joint, more of a consequence of age rather than actually of active inflammation. So it may be that is something that is worth investigating a little bit more, because steroids probably aren't the best treatment for treating inflammation associated with osteoarthritis, and maybe non-steroidals would be better. So maybe a change in medication would be helpful, but that's not something I can sort of answer with that information. But that would kind of be, I guess, where you're going, that other things might be causing a problem in the joint at this stage that we'd need to look at.
And again, that really shows that you've got to have a good rapport with your vet to feel confident, and the vet feel confident in you. Because just imagine me being your vet, and you've been with this low dose steroids for 6 years, and then vet me turns up new to the practice and suggests, should we try coming off of these because I don't think they're needed anymore, and the dog flared, oh my god. So it's a two-way street. Both people on each side of the table are a little bit nervous about change, and I know as a vet, upsetting the apple cart is something that we really do have in the front of our brain, and it can really influence decision making. Don't want to make it worse, so maybe we just stay where we are for now. Is that good enough? Well, in this situation, potentially not. As you say, the dog might be better treated with something else. This gives us a perfect opportunity talking about the IMPA and OA. Now, this is where, being a first opinion vet and not heavily involved in this world, I always assumed if you had inflammation in the joint, no matter the cause, that would lead to OA changes. It to me, it just makes sense. Is that not the case?
I don't think we've documented that. I think it's a bit like in human medicine. I guess we don't see immune-mediated polyarthritis very often, but things like gonococcal infections in young athletes, they don't seem to cause any joint inflammation or arthritis as they get older, and that's something I guess that we sort of assume to see in these dogs, that there aren't the cross-sectional cohort studies to be able to sort of follow them into old age, but I don't think we appreciate that they develop arthritis more than other groups do. Usually the inflammation is quite acute, and then we control that quite quickly. The sort of classic case, I would be expecting to get that inflammation under control in days to weeks, not that inflammation being a long-term thing. So you've got an acute inflammatory insult in the joint rather than a long-standing grumbling inflammatory insult. So in that regard, yes, it may be a trigger to OA, but if you've controlled that quickly, that shouldn't be a trigger to the development of OA in the longer term. If it's a chronic case where you're really struggling to control it and it's been present for a long period of time, then yes, that may precipitate OA. I guess you've got the conditions for that to happen. But in the kind of classic IMPA where you've got acute inflammation, you control that quickly, then no, I don't think that would be something that we would appreciate. But there isn't a degree of literature. I mean, you said you've been reading for a couple of hours trying to understand it, but the papers on this are based on very small numbers. So 20 to 40 dogs are big case studies for us. And it's really difficult when you're making decisions on a disease that presents in lots of different ways. They're not 40 cases that are all the same. They're 40 cases that are different. And then making decisions on the basis of that evidence is quite hard. So we're trying to collect some information. We're involved with a study with RVC at the moment looking at that, but it's difficult because every case is slightly different and people treat them in slightly different ways, and that makes it quite hard then to assess who's right and what the best way forward is. And a lot of it does come back to experience, because we've seen quite a lot of them and I can work with my experience, but as just a vet in practice that's not seen one of these cases before is probably working on what's in the textbooks. It's probably 5 to 10 years behind what we're doing and then referring. So it is quite hard. Yeah.
It is really, really hard. And yeah, definitely in the papers that I was reading, these dogs are, because they're retrospective, aren't they? So they're from different establishments that have worked them up differently. So there's different diagnostic workups over different time frames, there are different breeds, different age groups, there's different finances involved with different people having different amounts of workup, different drugs involved, different dose rates involved. So then being able to look at those 40 dogs, they're actually 40 very, very different cases. So it's hard to collate the data. Oh my God, Simon, you're really popular. Here we go, it's another one. My almost 2-year-old border collie is diagnosed with IMPA 2 months ago. The diagnosis was done the first day of the symptoms. Is it possible that a period or hormones can be a trigger? With her first period, she also had Demodex. It both started a few weeks before her period was expected. My vet doesn't think it is possible, but I keep thinking about it. Any link? Because there's no sex predisposition, is there? Gender predisposition?
Not that we recognise for IMPA. I guess testosterone is immunoprotective for some of the immune-mediated conditions with the hematological things, but I guess it's a little bit hard because Demodex and IMPA are kind of two separate things. So IMPA is the immune system overreacting, whereas the development of Demodex is probably the immune system being underactive, because the immune system normally would get rid of Demodex, which is a little parasite that lives in hair follicles, so the sebaceous. So it sounds like perhaps the immune system isn't behaving properly all the way through, but I'm not sure that that's necessarily hormones, because most of the hormones associated with estrus would be slightly immunosuppressive to allow the establishment of pregnancy. So that would fit with Demodex, but wouldn't necessarily fit with the IMPA. But we don't really recognise sort of estrus or coming into season as a trigger for immune-mediated disease in any of the conditions that we treat. So that may be more coincidence. It may be just that the immune system is not behaving in a sort of standard way, so any change is therefore perhaps more likely to trigger off a disease. But yeah, we don't know, and we don't have the tools to really look at what the immune system is doing in these cases, which is really hard then to try and understand what the cause of the problem is. I guess that is the question most people ask me, is like, what have I done? What could I have done differently? What could I have done to stop this condition happening? And the answer in most cases is nothing, because this isn't something that's happened because of any management condition or anything that we could have stopped from happening. It's just one of those things that essentially is bad luck and chance that the immune system is misbehaving, and we need to deal with that. But a lot of people do get really hung up on that question, is why? And it's really impossible, because we don't have a good answer to that condition at all, which is really hard. Yeah.
It's really, really hard, and you can understand why people will start trying to pinpoint and bring things together, and they're doing 1 + 1 = 5. But I think that was a perfect explanation, and I definitely learned a lot from that as well. We've had a request about holistic options for treatment. Well, we haven't actually talked about treatment yet, so let's go through what we would say the evidence-based, what we know now with regards to treatments, and then we can go into holistic. So I think we've done diagnosis. Yep. Because we've talked about all the long workup and the fact that the vet can be looking like they're looking everywhere bar the joint. But hopefully you understand why they're doing ultrasound of the abdomen, chest x-rays, blood samples, urine samples. So let's do treatment. Go.
Cool. So I guess the difficulty with treatment is that we don't have a good evidence base for treatment. So when we're treating dogs with IMPA, essentially what we're trying to do is damp down the immune system response. So we're trying to stop the immune system from overreacting and causing this inflammatory reaction in the joint. And most of the time we'll use immunosuppressive doses of steroids to be able to do that. And they usually work very well. So these are steroids used at quite a high dose in the first instance to really control and suppress the inflammation. And then we taper that dose usually quite quickly and gradually withdraw it over a sort of 4 to 6 month period. Sometimes it's longer, sometimes it's shorter. It depends on the individual patient. But that high dose of steroid is the bit that is generally accepted as being the most effective treatment for immune-mediated polyarthritis. We would use prednisolone in the UK, and that's often prednisone in the US, and they're exactly the same drug. They work in very similar ways. But there isn't a paper I can show you that proves that works, because this isn't something where we have literature that is deep enough to understand what the best way forward is, or what the right strategy for using steroids is. And that's, again, some of the work that we do at the moment, is understanding whether once or twice a day steroids and how quickly you taper them and the differences between the strategies would be helpful. And that's really useful information that we need. And that's quite a safe way of doing it, just looking at the ways that different people treat the disease in different ways, comparing the outcomes that they have. But it's going to take time.
Can we just pause there? Just pause there. I think you need there's a really big point to be made there. When you've got a condition that is not very common, and it's a painful condition, it's a very worried owner, being the vet that goes, oh, I'm just going to try something new. Oh yeah, how do you feel about that? You're not necessarily going to like that approach. So that's why a lot of people do what has historically been done, and that can sometimes affect this kind of, what are all the different treatment options? Well, hopefully you can understand why vets will use what they know has been used before and in the literature. Sorry, carry on, Simon. I just had to say that.
No, that's fine. And steroids, I guess, would be the mainstay of that treatment. And it's really hard, because usually if we have the kind of classic IMPA case that comes in with really swollen joints, we use steroids at high doses on day one, and that inflammation gets back to normal quite quickly. And by 2 weeks out, the dog is behaving very normally, but we're still giving quite high doses of steroids, and those can cause side effects. And over time, those side effects perhaps become more of a problem for the dog than the initial dog disease did in the first instance. And that's where we run into trouble, that sometimes if we withdraw those doses too quickly, then it does come back, and that causes a problem, or we worry about it coming back. So learning how we taper these medications and how we're able to reduce the dose is really important, because getting the dog onto the lowest possible dose of steroids but not having a flare-up is kind of a delicate balance. And that's where judgment and experience comes in, and regular examinations and doing things like CRP monitoring to make sure that we are making those right decisions. I guess steroids are tricky. We see that dogs tend to drink a lot, eat a lot. They lose some muscle mass associated with steroids at high doses. And just being unsettled, and the psychological things. You put people on high doses of steroids, and you can get some really weird psychological abnormalities as a result of that. And we don't appreciate that in the same way with our patients, but we know that they're not quite right. So getting the dose as low as possible, as quickly as possible, is really important. But that's often a little bit into a journey into the unknown, rather than is a very set process and a very set way of being able to reduce it.
Do you reduce like in a two weekly interval? If you had a textbook case, would that be the sort of thing that you'd be?
So I think the sort of standard, we would use 2 mg per kg once a day as a starting dose, which is a fairly hefty dose. I don't tend to ever go above 50 mg per kg as a total dose for any patient, because I think you don't see any better effect. But that's just what I was taught during my residency, and I think a lot of people sort of subscribe to that, but it's not something that's sort of embedded in the literature. And then we'd usually decrease the dose by about 25% every 3 or 4 weeks, but it does depend on the individual patient. If we see dogs that are super sensitive to steroids, because you do get some that just drink buckets, and then it's just impossible for them to live with their owners if they're drinking that much, that actually then reducing the dose more quickly or adding a second line immunosuppressive agent is then helpful to maintain that immunosuppression. I think for IMPA it's difficult. We don't tend to use second line immunosuppressives, at least initially, because the main response is usually steroid. Whereas for some of the other immune-mediated diseases, we do use second-line agents from the off in terms of trying to reduce the amount of steroid. But that's again because of the literature not being that strong in terms of what to expect and what to use, and also a lot of personal preference in terms of how people treat these. So if we do see dogs being very sensitive to steroids, a second-line agent to reduce the amount of steroid that you need to give, but take over some of the action, can be very helpful, and that might be a sort of balancing act that needs to be put in place.
Right. So let's talk about that, because there's a few, and we had a question that a lady that couldn't join us was talking about cyclosporin, wasn't it?
Yep.
Was it azathioprine?
So I think virtually any immunosuppressive drug that's been used in clinical practice has been used to treat IMPA, and we have some small studies for some of them, and we don't have evidence for a lot of the others. So, for example, azathioprine is a immunosuppressive drug that acts to essentially reduce antibody production and can be very helpful in terms of treating a lot of the immune-mediated conditions we treat with anemia and thrombocytopenia and so forth. We have a huge amount of evidence how it works in IMPA, but we would assume that it would have an action. So for treating a lot of the conditions, steroids and azathioprine would be our sort of go-to choice. And if we wanted some background immunosuppression, then azathioprine would probably be the drug that I would go for, because it's relatively safe in the context of what we're using, and it's not a particularly potent immunosuppressive, so it would be expected to take over some of the action of the steroids, but it's not necessarily going to add a huge amount to the steroids in that respect. If you wanted something to add to the immunosuppression of the steroid, then usually you've not got a condition that's easy to control. In that case, we need to be absolutely certain that there's not something triggering it off, and that's generally where people come unstuck, that we see a lot of dogs where they have IMPA and they're giving an awful lot of medication, and it's not that medication isn't working, it's that there's something that's triggering off the immune system to cause the problem, and actually we need to treat that and do that initial workup rather than just giving drugs. But I guess then that's where things like sporin and leucomide and Ramsel all come into play, because those are drugs that potentially would be useful in that instance.
So would it be fair to say, if you've got a dog that isn't responding well to the steroids, in that it's not controlling the actual disease, so we're not getting rid of the effusion, the pain, we haven't got an improved range of motion, we haven't got an improved quality of life, then some vets might go, we need to actually reinvestigate. There is something that we haven't found. So is that fair to say there, that an owner might find that their vet goes, stop, let's look again,
Yeah, I think so, and it's one of those things that is a bit of a balance, as you're saying. I think finance comes to this in quite a lot. We would always, or I'd always prefer to spend money on treatment than on tests. So if there isn't money to investigate, then usually we spend the money on drugs rather than doing a lot of testing in the hope that that gets things better. But if there is finance to be able to do testing, what we would call restaging, just having a look and seeing if there is something that's triggering this off, would be very sensible. If you've upscaled the immunosuppression so much that you're just not controlling it, then having a look and just making sure that something that wasn't easy to see or couldn't be found when that first investigation was done isn't now obvious. So a bit like the chap earlier was saying, there was a mass on the spleen, maybe there was something like that was developing and now is causing a problem, and the immune system was reacting to that, but we just couldn't see it when we did the initial ultrasound because we can't see those sorts of small changes. So restaging and having another look at a later point would be very sensible if you're not being able to get on top of the condition. So maybe 6 to 8 weeks in, if you're still really struggling with medication, then we would restage at that point.
Okay, and I think the question was, the dog was very sensitive to steroids, wasn't it? And she'd been on long-term azathioprine, and they'd been reducing the dose of the steroids, but the dog was still on the azathioprine, and she wanted to know, could she stay on that long-term, because she was so scared of having another nasty flare. What's your thoughts on long-term azathioprine?
Yeah, so I guess we use azathioprine as background immunosuppression. So I would use that as sort of long-term medication. So you usually use it once a day for maybe 3 to 4 weeks until the condition gets under control, because it does take about 10 to 14 days to start working. So it's not something where you give it and it has an immediate action. And then you move to every other day treatment. And usually that stays as sort of background treatment whilst you bring the steroid dose down. And then once you've withdrawn the steroids, the aim is to reduce off the azathioprine dose. I guess the difficulty is that azathioprine, like steroids, isn't a completely benign drug. It can cause myelosuppression, so reducing the bone marrow ability to produce cells, so white cells and red cells and platelets, which I guess is what we're trying to get it to do in the first instance, because we want it to suppress the immune system a little bit. But that can be really difficult then to treat. If you affect or damage the bone marrow, then that doesn't necessarily always come back. So I would want regular blood tests at least every sort of 4 to 6 months to make sure that the bone marrow isn't showing any signs of a problem. And it can also cause hepatotoxicity as well. So the liver can also be unhappy with azathioprine as well. So usually those points we would measure some liver enzymes as well. But yeah, I guess it comes back to whether we need to be on the azathioprine. If we needed to be on immunosuppression, being on long-term low-dose azathioprine for me would be a good strategy rather than being on low-dose steroids in the longer term. So it depends on the sort of clinical indication and the time course associated with that. Yeah.
Okay. Well, that then leads us nicely into Justine's question, which is, are there any holistic options for treatment? Sorry, I keep clicking that. Now, that's a kettle of fish, isn't it? Because if we've got limited data about, the Western-based, medicine approach, then bringing in holistic, which I assume you're talking more along the lines of supplements, etc. I doubt there's very much literature out there at all.
I don't think there's any, and that becomes very difficult because people don't have experience in doing it. I don't have any experience in, well, we treat some of these with holistic alongside, I guess, and I'm very happy for that to happen. But a conventional approach is usually the way forward because it's an inflammatory condition. It's the immune system misbehaving, and these are pretty serious drugs when we're talking about immunosuppressive steroids and cyclosporine. These are drugs that are used for transplant medication in people, so they're fairly hefty drugs to suppress the immune system to control that. And I'm not sure there are other ways that you can really get the immune system back under control in that regard, unfortunately.
No. I think it would be fair to say if an owner wanted to do it alongside, if I was their vet, I'd be saying, right, let's work together. If you've got a naturopathic vet that wants to protect the liver and that sort of thing, then yeah, let's work together. But as I say, I'd be thinking very much of the dog, and I would be thinking, I want to get that dog's discomfort under control as quickly as possible. And I'm going to use something that's got more evidence of working than a see how this works approach. We're running out of time. Oh my God, they're still coming. Simon, it's insane. Wow. We're not going to answer all these. These are essays here. We've certainly hit a topic. We might have to come back and do it another day. Let's do Lee's one. My boy has been diagnosed with polymyositis. He does have some muscular fibrosis as a result of the condition. He has started weaning off the pred and is on mycophenolate, although after what has been a long and scary period, he seems to be getting a bit stronger. How likely would he be to get IMPA as a result of his condition? Thank you. So polyarthritis.
They're two different things, aren't they? So polymyositis means that poly just means multiple, and myositis means muscular inflammation. So that's a slightly separate condition than a polyarthritis, which is focused in the joint, whereas a polymyositis would be focused on the muscle itself. So if the polymyositis is immune-mediated and is coming under control, then it's, I think, very unlikely that we're going to develop another immune-mediated condition at the same time. Usually when we're thinking about these sort of lupus conditions, which have maybe polymyositis and polyarthritis or hematological abnormality associated with that, they all come up at the same point, or they sequentially come up, or you can't find it very easy to treat the first condition. So I think if the dog's doing very well, it's unlikely that it's going to develop another immune-mediated condition, but I think it's quite hard to answer that question. It sounds like that's quite an unusual diagnosis and a fairly hefty immunosuppressive protocol, so I suspect somebody with a reasonable degree of experience has been involved in treating that, so probably posing a question to them would be better. I think it's unlikely that immediate condition is going to happen sequentially. Usually they happen at the same time.
Okay, this is a very good question. She was pretty bad with extremely swollen joints, is doing well on steroids, but is having pretty bad muscle atrophy all over. Is this common, and how can we help when the joints are painful? That is something that I think is a very relevant question that a lot of people will want to know more about.
Yeah, I guess that comes back to knowing exactly what you're treating. So steroids at high doses will cause the sort of side effects that are annoying, like polyphagia and polydipsia, so drinking more and eating more and just being hungry all the time. But I guess the thing that's going to affect mobility is the muscle wastage, and some dogs can be incredibly affected by that quite quickly. So you just see the muscle just drop off over the head, and they have really sort of dented temporal muscles on the top. And that really worries me when we're using steroids at those sort of high doses. Control things, that mobility is going to be an issue, especially if there is underlying joint problems as well. So I guess the concerns there will come from losing the muscle mass and the effect on mobility. But if that's still associated with joint pain, as in we haven't controlled the joint pain in the first instance, that maybe we need to have a better immunosuppressive strategy, so using something else so that we can reduce the steroid dose, or being more aggressive at reducing the inflammation in the joint. Because if we're having to use really high steroid doses on their own and just seeing that the muscle mass is dropping off, then we're probably not addressing the underlying condition effectively. So I would kind of go back to the strategy as to whether we could reduce the steroid dose and whether we could do something else, or potentially whether there's a degree of arthritis in that joint that's causing some discomfort, rather than this is still the ongoing inflammation associated with IMPA, and that might be a condition where we would consider joint taps to try and tell the difference between those things, depending on what's going on in that individual patient.
I think that also opens up that discussion that you need to be working with your vet, because there are going to be a lot of owners that potentially are still giving a too high a dose of steroids because they haven't gone back as frequently as possible, and they haven't got that great working relationship where as soon as the opportunity arises to reduce the dose, that is done so. And I know I've had clients that seem to disappear and then they come back, later than expected. So again, both sides of the table need to be working on this condition to make sure you get it right. Oh, we're going to do 2 more and then we're going to have to call it a day. My dog has idiopathic IMPA diagnosed about 2 years ago. He's 11 years old now. Recently, we tapered down Pred and got him off for a few days before he had a flare-up. And now he's back on steroids. I'm a new graduate vet. I'm not sure if it's a true flare-up. It may have been, but my vet didn't do any exam or tests, or he was in so much pain from severe OA of the joints secondary to long-term steroid use. I believe steroids can damage joints. Now I am in a situation where I feel I have to keep him on steroids, and this may continue to damage his joints, as I cannot give other anti-inflammatory drugs to control his pain whilst on steroids. But he's in too much pain in the 5-day washout period to stop steroids completely. Any recommendation for other drugs except paracetamol? He's on this already. Ooh, long one.
So I'm not sure. So this is a dog that has IMPA that has some osteoarthritis as well in the joints. So coming off the steroid essentially unmasks the inflammation associated with the arthritis. I think that's tricky, isn't it? Because the steroids will control the inflammation associated with both OA and IMPA at quite high doses initially. Yeah, I guess it's the steroid damage to joints. It's difficult. Again, there's not a lot of evidence about that, but I guess we worry about potential cartilage damage in terms of very high doses for very long periods of time. But I guess having a strategy that helps to reduce inflammation and helps to manage the pain associated with the joints would be the way forward. I mean, most of the analgesics that we use can be used with steroids. So, I mean, mentioning paracetamol there, but things like gabapentin and amantadine are all things that we could concurrently give at the same time to try and control some of that discomfort whilst we reduce the steroid dose. But yeah,
I'm going to be outrageous.
It's very hard to answer that question. Yeah.
If this was a palliative care case, would you ever use PLT?
Yeah.
Because I had a vet email me the other day. I went, "Oh, you're probably too young to remember the poorly leg tablet, Hannah." And I was like, "No, I remember the poorly leg tablet." But it depends if it's palliative care and case, I guess.
It depends on the dose of steroid as well, doesn't it? So yeah, balancing that up against things. I guess it would be a reasonable strategy in the longer term. And I used to like using PLT a lot, and it does work. But yeah, balancing that against the discomfort is difficult. And I guess without knowing a bit more about what's going on, that's quite a hard question to answer. So
would you encourage this person to go back and see the vet and say, "Look, I'm really happy for us to do further tests if you feel that they're required," i.e. sometimes I feel vets need a little bit of the green card of you can go ahead, because I know sometimes as a vet I feel quite inhibited with the owner's impression of what they want, and I'm like, "Oh, I really would like to do further tests, but I can see the door is down, and how am I going to get where I want to be without being allowed to do further tests?" Sometimes an owner going in and saying, "I expect further tests, I'm happy for further tests, I'm with you on the further tests, do they need to be done?" can sometimes open that avenue of treatment.
Yeah, I think that's really important, because that helps to direct where we're going. So we can take the easy choice, which is just go back onto medication, or we can do something that's more difficult, which is to investigate a little bit more. It sounds like this person was a vet, a new graduate vet, so I'm not sure who was the decision-making person in that process. But yeah, it can be really hard as a vet owner to make the right decisions. I'm hopeless when it comes to treating my dogs. So yeah, very happy to have a chat with you if you want to get in touch.
Yeah, so Simon works at Dick White for referrals. There you go. Laura McShane, come on, show yourself. Absolutely brilliant to hear there's some ongoing research taking place. I think one of the hardest things about this disease is how random it seems and how helpless we can feel as owners when we see our dogs in so much pain that their own bodies are almost creating. Thank you for the reassurance that we've done nothing wrong. This is a very informative chat. Thanks, Laura. That means a lot. We've got many more questions under there, and we've got loads of thank yous. Hannah, I am so sorry. I'm just joining. So glad you're still going. Hannah was the person that had the questions, and she was really, really sad not to see the actual live. Hannah, get your question quickly now. We'll do 10 top tips, and if there's a question that you really want answered, we'll do it at the end. But otherwise, we're going to do the classic CAM thing, which is 10 top tips, and it's about OA. Okay, guys, because I know we've chatted about IMPA, but we are going to go back to our core, which is OA. And Simon has been prepped. He has had to come up with 5 things, and we're going to take our time doing 10 top tips. And I'm going to start with number 10, and I'm going to steal one he's probably had, which is weight loss. Oh my God, I'm so passionate about this now. Please, please, please do the foundational stuff. I'm going to be a little bit controversial. When people talk about holistic means treat the whole. And sometimes I find it quite daft when those foundational changes aren't done and somebody's spending a fortune on supplements and therapies and stuff, and their dog's carrying 5 kilos too much weight. Do the simple stuff. We know it makes a difference, not only in the development, but also the progression and the pain. Weight loss, weight loss, weight loss. Number 9.
Perfect. Yeah, and I'm just going to hold my hand up at this stage. So I am the owner of a 15-and-a-half-year-old Labrador who has quite bad arthritis. So I've had to learn a lot of this stuff as well. And weight loss is really tricky with her. So that's a really good tip. So my number 9 would be flooring, and just making sure that we have appropriate flooring in different places, especially when corners and things are needing to be turned quickly. It makes such a big difference to what my Labrador can do, just putting some matting down or just increasing the sort of friction that's present on the surfaces, on steps and things. So yeah, just having a look at where the dogs are going and how they're able to move around makes a massive difference, and just changing the flooring in those areas where they're needing to make turns quickly can make a really big difference. Yeah.
Number 8 is on the similar vein to flooring. Something else I've become very passionate about: nail care, nail and foot care. In that I can't stand it. You see these nails and they're so overlong and they can't actually engage their pads, and they're rocking it onto the back of their pads, and their whole posture's adapted. Any age, please, guys, look at your dog's nails and foot care. A lot of breeds have like quite a lot of fur between their toes that's going to cover the pads. Pads don't offer that much traction, if we're really honest, but put in a big sock of fur over them, it's not going to help at all. So what I try to do is get people to get some clippers. Amazon, you don't need to spend too much money. Vroom, get rid of the fur. Go at the back as well, because it covers over the metacarpal or the metatarsal pad. Vroom there as well, and keep the nails nice and trim so they have good posture, good contact. That's number 7 for you.
Perfect. I guess it comes back to using drugs, and people, I guess, don't want to give drugs unless they absolutely have to, but non-steroidals make such a big difference to quality of life. Not being afraid of starting those and using those is really important. So and changing them, if you've got one that isn't working, just making a change to use something different has made a massive difference. So we've gone through several different anti-inflammatories to find something that works for my dog. My dog's called Lumpy, by the way. She's called Sugar Lump, but Lumpy sounds really bad. I didn't name her. My wife couldn't name her before we got together. But so changing Lumpy's anti-inflammatories made a massive difference to how he got on. So yeah, not being afraid to say this isn't working, let's try something different.
Yeah, definitely. I think I'm going to go on a little bit further with number 6 is please do your damnedest to have a good relationship with your vet, because on that same note, I can remember when I suggested someone, let's change anti-inflammatory before we start adding adjuncts. The dog had been on a anti-inflammatory for 5-6 months and it had not really cut it, we were just not there. And instead of adding an adjunct, we said, well, let's try changing the anti-inflammatory. And believe it or not, the dog wasn't as good. It was worse on that one. Not through pain, but the dog became really sleepy and just wasn't quite itself. And the relationship between me and the owner became a little bit tricky. Not bad, but just tricky, because as their vet, I'd made a decision that hadn't been a positive one. But we pulled it back, we got it back, and we then ended up coming with an appropriate plan. But you do need to have a good working relationship with your vet, and that is a two-way street. You need to go in with the attitude that you want a good working relationship, and that vet needs to be able to give you the service that you're requiring. Number 5.
So I guess sort of going on from drugs, using adjunctive drugs when needed. So yeah, we don't want to use them as needed, but if Lump's having a bad day, we give some paracetamol or something else, and it does make a massive difference to how she can get around. So not being afraid to treat tactically with those additional drugs works really nicely. So having the anti-inflammatories as a baseline, but giving additional analgesia on days where things are having a problem is a much better way of doing things. So yeah, that tends to work nicely for us, using those additional drugs if they're needed, and don't be afraid to use them if they're struggling.
Yeah, definitely. Number 4 for me is exercise and lifestyle. So let's go with exercise. I used to do a one-on-one service where I went to people's homes because I was so obsessed about arthritis. 90% of people, I was telling them to exercise their dog less. Yes, believe it or not, less. So these were people that were hanging on to the life that they had, irrespective of whether the dog was coping with it. So there was one guy that was still running every day with his dog for an hour, because the dog would go to the door and go, yeah, that's the routine, let's do that. He assumed the dog was okay, even though halfway into the run, the dog was 10 foot behind and just trying to keep up. Look at the exercise quotient that you're doing. It probably will need to be adapted. And sometimes less is more, and sometimes you need to go back a bit to go forward a bit. But look at what you're doing with your dog rather than just adding more drugs and carrying on throwing the frisbee. It just doesn't make any sense to me. Number 3.
Yeah, I guess for me that would be the other side of that. Lumpy as a Labrador, she's quite lazy, so she doesn't do anything. So unless you physically get her up to do things, she doesn't move. So if you get her up every couple of hours and just make her have a little wander around, she's so much more mobile than just sitting around doing nothing all day. So we have to physically encourage her to get up, which is quite easy because she's a Labrador. So you offer her some food, and then if she wanders around for 5-10 minutes, it really helps with mobility. Whereas if you just let her lie down all day, so if we go out, for example, you really notice that in the evening when you come back, she's really a lot stiffer as a result of that. So just encouraging to make sure that they are doing those sorts of things is really important.
Yeah, I love that. And now I'm going to add to that. Think about what you do, look at your routine, and think about how you can adapt your routine to keep that mobility and get them up and moving. On a similar vein, I had one owner, all she did was in the morning, instead of leaving her dog to have a lay-in, which she thought was the kindest thing to do, when she got up, she got the dog up with her and they went for a little walk around the garden. She had a cup of tea whilst they just had a mosey. She took some of the food, sprinkled it around the garden, and the dog started loosening everything up. The rest of the day was so much better. So think about, taking your food, what can you do with it? That aliquot food, can you scatter feed it? Can you hide and seek it? Can you put it in toys? Make use of what you've got. We want them up and moving little and often, want them doing transitions, sits to stands, stands to lay, whatever it might be. Keep the joints moving. Number 1, the biggie, Simon.
Yeah, I guess for me it's focusing on the positive things, so things that she can do rather than things that she can't do, because I guess there are a lot of things that they can't do as they get older, which it does get a bit depressing when you think about where we were, but there are lots of things that she can do, and she still has a really good quality of life because she can do those things. So I think focusing on the positives is really important, and trying to create situations where those are achievable things, and quality of life is measured on the things that can be done rather than creating situations where there are things that they can't do, and that becomes really disheartening.
Yeah, no, I totally agree. And that's why Cam and the Cambastas and Holly's Army are amazing, because chronic diseases like this need a little bit more than 2D information. And me and Simon were just talking before we went live, is that as an owner, having had a dog with a chronic disease, which is Holly, Holly really broke my heart, and it was so difficult. And you could get the 2D kind of like the academic information, but you almost wanted it to come with a hug and some support and some advice, and that like the daily grind that you go through. So please take yourselves over to Holly's Army. It's a beautiful community group. It's run by the Cambastas, which are owners like you that may be going through it or have been through it, who've had extra education. So we privately educate them, and they're 30 to 40 amazing individuals that give up their time to make sure that Holly's Army stays friendly, evidence-based, and foundational. So when I talk about foundational, instead of getting caught up on the latest supplement that's being sold online, which be careful, they talk about weight loss, lifestyle change, all the things that are free of charge and really, really important. So, Hannah Walker, I can't tell whether my questions have already been answered. I think they may have been, judging by the comments. If not, I will save them up for next talk. Well, Simon, you've just been stuffed there. You're going to have to do another talk. I would say a massive thank you to Simon. I think he is absolute pleasure to talk to. So eloquent and so calm. And love it. So thank you, Simon. Really grateful. And hopefully all you guys will continue to say thank you. I can see many of you already have done. Hopefully Simon will come back at some point and he will tell us about Lyme's disease, maybe, because it's his favorite topic.
Yeah, maybe.
Maybe. Anyway, until next time, guys, I think there's another one on Thursday, but please do go to our events page, which is part of the Facebook page. Please join our newsletter. Go to our YouTube. We've got Instagram, Twitter, and we've got the Facebook presence. We've got the website, the conversations, the blogs. Please support us. We have an online shop that we try and fund this. It is quite expensive. It generally costs nearly £1,000 a month to run this platform. So please, go and look for a hoodie, a beanie, a bum bag, a baseball cap, and talk to your friends about how important this is. The more people that understand how chronic pain is expressed, behavioural change, etc., the more cases we will get to earlier and the better results that we'll have. So we need to be shouting "Your dog more years" across the rooftops. And you can do that by supporting CAM t-shirts, hoodies, as I say, baseball caps, booklets, own a modular course. All the money goes back into CAM. So thanks very much. Thank you guys for watching, and thanks, Simon. Till next time.